Thank you, Till, for that introduction. So, good afternoon, all, and thanks for joining us. My name is Mugdha Gokhale, and I'm a second-year doctoral student in the Department of Epidemiology. I'm also the chair of the UNC ISP student chapter. Since 2008, our chapter has been instrumental in helping organizing the Harry Guest Memorial Lecture. And really, the series was conceived up by the students to honor late Harry, who is really the father and the founder of the pharmacopy program at UNC. Today, we are honored to have with us Dr. Alec Walker, who's an adjunct professor of epidemiology at the Harvard School of Public Health, and also co-founder and principal at the World Health Information Science Consultants.
Thank you, Mugdha and Till. The idea of giving a talk with Harry Guest's name on it was something that moved me. Harry was a mathematician in his first life and actually became a professor of mathematics. Having done that, felt that he really needed to be more involved in events in human disease, went to medical school, became a pediatrician, and then combined his medical and his mathematical skills in moving into epidemiology. He had a distinguished career at Merck, but I think it was most distinguished because he changed the company in some really important ways. It was Harry that was the first really articulate spokesman for the idea that you needed epidemiologists who were capable of looking at diseases in ways that had never before been done. When Proscar was under development, he led a worldwide program to understand the epidemiology of benign prostatic hypertrophy, which really wasn't known particularly. And he brought to that organization the sense that epidemiologists have a lot to offer in pharmaceuticals. So I'm going to talk today about equipoise. We know very well that the different doctors give different treatments. So similar means that there must be a coexistence of a variety of opinions in the clinical community about what the best therapy to use is. So the varying treatments are evidence for varying beliefs in the community of prescribers, and this corresponds to something that Benjamin Friedman called clinical equipoise. But it's the idea that there are different people with different views, and they're equally competent but have come to different conclusions, and that's considered a permissive condition under which you can conduct an ethical clinical trial. If we look at clinical equipoise, identifying it with what I'm going to call empirical equipoise, which is simply this observed variation in treatment. We also have a permissive state for observational comparative effectiveness research. And where we're going to end up is in saying that if you really do want to do comparative effectiveness research, that rather than thinking harder and harder about sophisticated ways of controlling confounding biases, you might better spend your time looking harder and harder for good places to do the research where you don't have to be so clever in terms of your analytic techniques. And we're going to see if we can't find ways of finding those settings and simply abandoning the field where we oughtn't be doing it. So we're going to introduce some notation here. The sigma sign to indicate a provider. And the reason I've chosen that is that what prescribers do is sum up lots of inputs. They take information that comes into them and they come out with a treatment decision. Providers are confronted with questions all the time in the form of questioners, which are patients, who come with some problem to this summation figure who tries to put things together. So let's imagine a clinical encounter in which we have a patient coming in with a complaint and visits a provider, and a whole series of elements of knowledge and sort of prior inputs, if you will. And the patient with a complaint will either voluntarily or as elicited by the provider begin to give some more details. We'll talk about the symptoms, and you may find the signs of a particular. Of course, it's relevant to have a the history of what's a complaint, other illnesses at the same time, what medications, prior test results, and what provider may choose to do. And all of those go into the provider's summation and taking into account all the things that the provider has brought to the table on to a different provider. That different provider might have come up with a different, or to another provider, another treatment choice, or to another provider, yet another here. But if we have a set of information and a group of providers, we'll have a group of different outcomes. Now, I'd like to simplify the picture. Let's imagine that those providers will do one of two treatments. If it's the case that the chance of the same patient getting treatment A or treatment B depends only on which provider he goes to, then community of prescribers is in some sense in a state of equipoise. So we have this, it's not a chance element maybe which doctor you go to, but there are lots of determinants of it that don't have anything to do with your illness, and I'd like to think about this as equipoise. Equipoise as a term has history that goes for this article of Friedman's. If you're uncertain as to what's the better treatment, then some earlier writers in this area had said that that defined a state of personal equipoise. It turns out to not work so well, though, as a justification for doing trials. There's lots of shortcomings. Probably the most important of which is that this state of personal equipoise or ambivalence, this state of personal ambivalence about which is the better treatment is a very fragile thing. And of course, it's susceptible to information coming in. And it makes it very difficult to actually do a clinical trial in a state of equipoise. So you may do some preliminary studies to get you ready to do the trial, maybe some dose-finding studies. They're going to have some result. They're going to affect your opinion. If the trial isn't blinded, the early results of the trial are going to affect your opinion. You might have secondary endpoints in a trial so that you still are not at all sure which treatment is better from the point of view of remission of the condition that's being treated, but you notice the quality of life is much better. One group has unbearable itching all the time. The other group seems to feel pretty good. Well, this begins to affect your sense as to which is the better treatment. And of course, you can have data that are external to the trial coming in to affect your sense of balance. And that could be other people doing work along the way. It could be simply talking to your colleagues. You expand your circle of reference. And so it's really easy to fall out of a state of ambivalence about the trial. And so it's a very unstable way of motivating a trial. A number of writers recognizing this propose various solutions, some of which we still have with us in terms of trials. One of the original ideas for the data and safety monitoring committees had been specifically to withhold the results from the investigators, not because they would be led to do the trial in an incorrect way, but because they would fall out of equipoise if they knew too much too soon. You don't lose responsibility for something that's knowable by simply not knowing it. The informed consents were certainly part of it. The idea of informed consents was you could put onto the patient the responsibility for participating in the trial by telling them everything, so it didn't really matter what you thought. All that really mattered was what your autonomous decision-making patient thought. There were even writers who maybe only half seriously that this was such a difficult problem that the only way you could get out of it would be by having sort of a medical conscription, that people would be sort of obliged to stay in trials. Two of these have survived into the present day because they provide other benefits other than simply maintaining equipoise in patients, and we were all accustomed to DSMBs and informed consent because they have many other virtues. Going back to Friedman, we can consider some situations in which already, as he was writing, and certainly this is still the case, everyone would thought of a trial as equitable even while the ethicists were off talking about equipoise. There's a standard treatment, but there's evidence that another treatment might be better. Or that people have well-formed opinions and that they're different, that there's disagreement in the community about this, about what might be the right treatment course. And under that circumstance, this is what we're going to call clinical equipoise. We have a diversity of opinion, and this can have some reasonable qualifiers among knowledgeable people and so forth. And what's really helpful about this in terms of the specific problems of equipoise as a motivator for clinical for, or as permissive factor for clinical trials, is that now you can have a strong opinion. You personally can be convinced that one treatment is better than another, and yet still ethically participate in a clinical trial. And all that it requires is your ready acknowledgement that you might be wrong, and that your colleague who has a different opinion might be right. Interestingly, as we look back through Friedman's text, there's the justification of this is really around moving from the individual as the locus of knowledge to the community as the locus of knowledge, and replacing individual ambivalence with diversity of opinion in the community. As pharmacoepidemiologists, we rarely make deep inquiries into the state of beliefs of prescribers. We typically know what they've done. When we go back to our idea of all these different doctors who might treat the same patients, we realize what we're doing is we're talking about a community of prescribers. I'm suggesting that when the community is divided, we have something that we'll call empirical equipoise. And the suggestion is that empirical equipoise is an indicator of the presence of clinical equipoise. The real underlying idea you'll recognize is a problem in counterfactuals. So we're going to have to adopt some strategy for understanding when there's equipoise. We just can't observe what different doctors would do with the same patient coming out. So we have two sources of variation. The question that we need to ask is whether switching patients between the different doctors might have yielded different treatment assignments. And intuitively, we think that if we're going to switch them and you come out with the same result, that the treatment choices are really more reflective of prescriber beliefs than they are of the conditions of the patients. We can't switch the patient, but we can't ask whether patients are determinative of treatment, because we can't switch them. We can begin to amalgamate across populations and ask whether any patient characteristics seem to be determinative of treatment. Let's put that a little bit more formally. So we can say, if the probability of getting treatment A, whether or not this is a function of various patient characteristics, and of course you'll recognize propensity score. You have different treatments, and you're looking at what are the factors that predict treatments. If doctor preference is the major determinant of treatment choice, and we fit a propensity model with all these different patient characteristics in them, most of those coefficients are going to be 0 or near 0, apart from some random fluctuation, and all the fitted values of a propensity score are going to fall somewhere near the grand mean. For the purposes of comparing different drug pairs and different groupings, my colleagues and I chose to normalize the propensity score just a tiny bit by subtracting out that grand mean, so that it would, and creating something called a preference score. So this is something which, in the absence of predictive power of patient characteristics, would come out to 0. So you actually go through and calculate propensities, and you make this little adjustment of the to center things, you get distributions which are fairly symmetric. Now, these data are drawn from the New Jersey PACE, a Medicare supplemental program that gives you help with drug costs. This is just a sample of convenience, really, but what we're talking about is old, pretty poor people in New Jersey. What we did was to identify people with community-acquired pneumonia. Among people with community-acquired pneumonia, looked at pairs of antibiotics. And for each of those pairs, we calculated a propensity score of the discrimination between them. And I'm showing you here two of the pairs. And the one on the left is azithromycin and levofloxacin, and the one on the right is clarithromycin and moxifloxacin. These preference scores, as you see, seem to overlap for the first pair, and they don't overlap very much for the second pair. And you'll just remember this is a transform of the propensity scores. And as is the case for a propensity score, it's the same with the preference scores, that any particular covariate combination, I've labeled 4 here, plug back into the propensity formula, leads you a particular propensity and therefore a particular preference here. And the heights of these two curves tell you if you are covariate pattern A, are you relatively more likely to be on azithromycin or levofloxacin, or D, you're more likely to be on levofloxacin versus azithromycin. Correspondingly, for the clarithromycin, moxifloxacin, we have other covariate patterns that put them more broadly because there's a broader overall probability distribution of covariates, and so they can be almost anywhere. Here's what I'd like to propose, that when most people have covariates that are very similar, that we're in a state of empirical equipoise, and we can put the particular covariates that we looked at back in here, and they fall within a range. Now I've drawn some lines that correspond to odds of 2 to 1 or 1 to 2 of getting one treatment or the other. And those overlapping curves at the center mean that most people, in fact, fall into that range. By comparison, if we do similar bars at 2 to 1 odds of getting one treatment or the other for the clarithromycin moxifloxacin comparison, we see that there's relatively few people in that category, or at least relative to the others. And I would say that here we're in a situation where we have, I'll call them patient different preferences, but it could have been patient different determinants of which drug got used. So most people are in categories of health states and the like that tell the doctor, give the doctor a strong preference for one treatment or the other. Now, if we go back and look at those people who are, those populations that are in empirical equipoise, and you can work through why this should be reasonable that it's so, what you have is very similar distribution of patient characteristics between the two. This is the levofloxacin and azithromycin groups, because if there were any moderately prevalent characteristic that was quite different between them, then there would be a corresponding lump of people out over in one of those tails of those distributions, and we've just observed empirically that there aren't any such lumps in the tails, and therefore we have this balance. Now, if you look at people for whom there seems to be this balance occurring naturally, this is not one that you forced in by study design, when it's just naturally the case that doctors are giving pretty similar patients these two drugs, then the proposal is you can just compare them. Here's the results for looking at treatment failure, which was defined as hospitalization for the pneumonia or a switch of antibiotic within 10 days of starting the treatment. And there are actually quite different rates for levofloxacin and azithromycin. You see that the rate of treatment failure was lower by that much, at this level at least, among these patients who are pretty similar just because they were similar, that we had a substantially lower failure rate. And here's back to that table. This is a crude relative risk. Having done all this propensity calculation and so forth, you can do further adjustments which come to about the same as the crude result. So we've got a situation in which we've got good reason to think that the difference in treatment assignment is due to non-patient characteristics. There is a difference between the patients in terms of their outcomes. And this is one that's non-trivial. You know, if one of these two in these elderly people has 28% lower failure rate, that's the sort of thing you'd want to know. I'm not proposing that this is definitive research on this topic. You know the joke about after the faculty party, you find Till out there looking for his car keys under the light, and another faculty member totters up to him. Till says, "I've lost my keys," and he says, "Well, why are you looking under the light?" He says, "Well, this is the only place where I can see anything." This is really that kind of model. This is this kind of analysis of large bodies of data is simply telling you where the lights are in the parking lot. That doesn't mean that that's where you ought to be doing your comparative effectiveness research. You're going to have other standards for that. But this is telling you where you can do it. Other places, maybe you need a flashlight. That flashlight is randomization. Let me come back a little bit to talk about this expectation in here. If we've got balance on the observed variables, does that really mean that we've got balance on the unobserved variables? One answer you can just put as in kind of a narrative form. The observed variables, and we have to assume that we're dealing with a rich medical data set. So we have the observed variables, which are all these patient characteristics and patient histories and all these things, are giving us maybe not definitive information, but they're giving us an awful lot of information about how prescribers respond to patient characteristics. And if we know that prescribers are not responding in terms of treatment discrimination to a whole series of things which we surely think would be important, then we might guess that if there are other unmeasured covariates, but if there are other known characteristics the prescriber knows, we've already seen that in the case of 30 other relevant factors that the doctor didn't make, that wasn't the determining factor. But it doesn't seem very likely that there should be something which is not reflected in the record at all, but which the doctor would find out routinely, which would drive you in one direction. All right, which is to say, is likely not to be confounders because of that arm of driving the treatment choice. You could very well have unknown strong determinants of outcome, say genetic ones, but as long as they're not known to the doctor, they're not confounders of the association. Another way that we might pose the same response is to sort of make a syllogism. So we know that different patients get different treatments. We know that patient characteristics in these situations where we found empirical equipoise, that patient characteristics are not determinative of treatment choice. Therefore, what can be determinative of treatment choice in the situation we're looking at? Well, it's got to be instruments. Okay? They may be unmeasured instruments. But what do we mean by an instrument? We mean factors which drive treatment selection that don't affect the outcome risk. It is the fundamental hypothesis in observational research that there are unmeasured instruments. If you didn't have instruments, things that drove the treatment choices, you wouldn't have anything to compare. And when I've been talking about doctor preference, what I've been talking about is one way of formulating one class of instruments. If going to Elizabeth gives me treatment A and going to Cindy gives me treatment B, that prescriber identity is an instrument. Predicts the treatment choice, doesn't have anything to do with the disease itself. You have to postulate instruments. In fact, it's a stronger necessity. All the time we say, assuming no unmeasured confounding, and feel like we've sort of been pure. Even more important than that is we also have to say, assuming instruments. Can't articulate what the instruments are, we might be skating on thin ice. You're certainly operating in a situation of hope. But this is absolutely a requirement for our relative lack of bias in an efficacy study. And that's that the treatment variation due to uncontrolled instruments is much larger than the treatment variation due to uncontrolled confounders. How much larger it has to be is a function of how strongly the confounders predict outcome. But it's not just a matter of what kinds of confounders you've got. You can have very few confounders in a situation where you've got no instruments, and the confounders are still the predictors of treatment choice. So you really need both of these pieces in order for it to work. I think that our usual technique of calculating a propensity score is a very efficient way of screening for unmeasured predictors. If we were in a slightly different discipline, we might be talking about latent variables here. This is essentially the same idea, and we use a lot more in epidemiology, this notion of proxy. A perfect proxy is something which is not necessarily a perfect correlate of the thing you're trying to control, but it's something having controlled for which you don't need to know anymore about the original underlying variable. This is a little picture of a proxy. We've got an underlying health state, which we take as strongly discriminative of treatment. So this is something which, if we could measure it well, would enter into a propensity score. On the left there's the proxy value. You see these are pretty highly correlated. The dots along the y-axis show you that the discrimination is not really nearly as good on the proxy measure as it is on the underlying health state. And we've got this thing which is unknowably but correlated with the underlying health state. Well, we don't get typically to measure both the proxy and the truth. What we typically get are two proxies. So if we want to talk about the severity of COPD or the severity of diabetes, we'll have lots of different things that we've measured, whether or not people are getting oxygen, whether or not they're getting various drugs. And so we'll measure all these things simultaneously. And when we look into our data, we'll see something like this, that each of the proxies is, assuming they had a structure like the picture before, the proxies are correlated with one another, and that they're each modestly predictive of treatment. It is a statistical fact that there is some function of those two proxies which better discriminates treatment than either one of those proxies alone. One of the things that we can think of ourselves of doing, of the things that go into multivariate analysis or proxy variables, is we're triangulating on that unmeasured covariate. The two different candidate proxies actually represent entirely different components of some underlying health state. Imagine that we had some notion of severity of diabetes. So we want to control for severity of diabetes in analysis. And we do a hemoglobin A1C, and we also look into a person's fundus, look at retinal vascular disease. If severity of diabetes means anything, they're both correlated with it, but they're uncorrelated. They're not related at all to one another. Just sort of imagine a little study. Let's say we were thinking about thiolazine diones, rosiglitazone and pioglitazone, as possible predictors of myocardial infarction, and we wanted to control for underlying severity of vascular disease and making that comparison. Arguably, you could use retinal vascular disease as a proxy for vascular disease, and there would be some biological rationale for it, and you would presumably reduce confounding if you controlled for it. By comparison, if you considered somebody's hemoglobin A1C, which is following down a whole different causal path, and you controlled for that, even though it's a proxy, you wouldn't affect the confounding. So, given this idea of proxies being mismeasurements of the same thing, or sometimes mismeasurements of different things that you have under your conceptual category, we have another setting in which was really quite different from the one I just talked about, in which proxies arise, in which we find that they're uncorrelated. One, even though they're both proxies for the same thing we thought, one is a good predictor of treatment and the other is not. They're uncorrelated with one another, but it turns out that it takes you to the same place if you're doing a multivariate analysis, if you're calculating a propensity score. If we adopt a rule of retaining things that seem to be predictive, and we will come out with the right answer. If our two measures are proxies of the same thing, then we're triangulating on that unmeasured covariate. If they stand for different things, then we're leaving aside the non-predictive unmeasured covariate, and we're pulling in the measured covariates. I'd like to suggest propensity kinds of analyses do a pretty good job, at least go in the right direction, of capturing the measures we need, and that they're a way of finding common unmeasured confounders. And then to take the argument back to where we started, that if your propensity scores aren't finding any discrimination between the populations, then you're in a setting where you're probably not having a lot of unmeasured confounders as well. What we've gone through is sort of different ways of thinking about this argument as to why it is that populations which are very similar when in their free living state, why that gives you confidence that they're also similar with respect to things that you haven't measured. It's surely not a pure logical conclusion, but I think that there's a lot of good reason to believe it. Recapitulating our initial ideas, that when doctors give different treatments to the same patients, there must be a variety of opinion about therapy in the community. And that variety of opinion points, at least under some circumstances, to clinical equipoise. And the clinical equipoise is identifiable in observational data as what we're calling empirical equipoise. And clinical equipoise, at least, is a permissive factor for valid comparative effectiveness research without randomization. We can't go along here without coming back with a note of caution. So we've talked about these multivariate analyses. We've acknowledged that there are these unmeasured characteristics which might be present in an individual. and we've realized that another individual who has the same measured characteristics might have different unmeasured characteristics. And that, we've taken this assumption that the similarity in the measured characteristics points to a similarity in the unmeasured characteristics, but nonetheless, it might only be apparent. These things might be different, which is why all of this exercise I wanted to talk about just as a screening exercise, as a first step to figure out where you can do good empirical hands-on research. I don't see this in any way as a replacement for it. You really need to always worry about these things, and this is why we go back and we review charts, while we look at things more critically, while we have human beings rather than machines screen profiles, or we get patient-reported outcomes when we can. But what we've really done here is we've identified situations in which we're not putting impossible demands on those factors, and so there's some reasonable expectation that you can go forward and get a valid answer. Let me just quickly commend this particular article to you, and really most of all say thanks to Harry, who does motivate me day to day in thinking about how he approaches problems. Thank you.